So I will go ahead and get back to you in a second. See what's going on.
I'm here.
Oh, you're here. Okay, that's perfect.
Yes.
All right. Well, good morning. How are you?
Good morning. And it is, I'm sure the person in Colorado Springs knows as well. We had a fair amount of snow. We got about 6 inches last night, and it was 12 degrees overnight.
Oh my gosh.
Yeah.
And here I was whining because it was 21 degrees here.
Well, 21's cold. That's definitely cold. But
I am not a winter person. So let me get some introductions going on. One of the reasons why I wanted this particular topic, we're going to talk about a good evaluation for kids, is because CCHD screening has become such a great thing. It has worked so well. But I was reading some articles about there are a lot of things that just don't show up on that. So we have invited Dr. Michelle Grenier. Am I saying your last name right?
After my dad was in the Army for 30 years, it turned into anything you wanted to pronounce. So
yeah.
That's probably the easiest way, and I appreciate the introduction.
So she attended Eastern Virginia Medical School, where she obtained her MD in 1988. She completed her internship and residency at Johns Hopkins from 88 to 91, with a fellowship in pediatric cardiology, which was completed in 94. She spent 8 years in cardiomyopathy and transplant with Dr. Jeff Taubin in Texas and in Cincinnati Children's. Interspersed with rural solo practice in rural Mexico, Appalachia, Mississippi, Visalia, California. I am just not very good this morning about pronouncing things. She continues her work in myocardial mechanics and fetuses and neonates while working in imaging at the Children's Hospital of Colorado. So welcome, Michelle. I'm glad that you could join us today.
Thank you so much. And I appreciate everyone's patience with me. So I gave you the introduction of the snowy day because the person who was supposed to cover me in the inpatient lab, their daycare was closed. So I'm going to hope to get through 45 minutes without any emergencies. And with that, I will open my talk. I'm hoping I'm opening the right one. Okay, everyone can see?
Yes.
Thank you so much. Okay, I'll move forward. And if anyone has questions as we go, I usually work on an ongoing dialogue, and unfortunately, we can't do that. I'm not there, and we have 50 participants, but please send chats, thoughts. If things aren't clear or you have experience or questions, please feel free to send me your thoughts. And we will have some questions that are audience participation. Congenital heart disease screening, as we were discussing, has become just imperative. And in the bad old days, we'd have those surprises at 2:00 in the morning. We still have some of those, but they tend to be less now. And especially with the onset of prenatal screening, we have decreased the number of urgent consultations. However, there are some areas where we could do a little bit of work, and we'll talk about that today. So our objectives today, I'm just going to change the screen a little bit. Our objectives today, are to explain the purpose of newborn screening, discuss which cardiac lesions are identified by pulse oximetry and those that are not, explain neonatal transition and complicating factors, and decide when to start prostaglandins and call for support. So congenital heart disease affects 0.8 out of 100 babies. So we say about 1% of babies have some sort of congenital heart disease. It's not all complex, but that's a fair number. Complex congenital heart disease accounts for 24% of deaths that occur in infants that are born with heart defects. So it's pretty serious. There's a fair amount of morbidity and mortality in those that live. The problem is a lot of times babies appear well shortly after birth, and you may not hear a murmur at all. So you may not have a tip-off. So we rely on pulse oximetry, although even that is not 100%. We're hoping it's 100%, but it's not. Sorry, bear with me here. Okay, so case one. This was a 2.5 kilogram male infant, once again born at term, APGARs of 9 and 9. So he looked great shortly after birth. He goes through that 24-hour window of time where he's transitioning. He does well. He's in no distress, but for whatever reason, his oxygen saturations hover 85 to 90%. He's breastfeeding well, but his saturations don't seem to come up on supplemental oxygen. I'm asking a question, unfortunately, you can't answer, but think in your mind what else you would like to know. And I'll go to the next slide and give you some information. So he's 51 centimeters, 2.5 kilograms, heart rate's 150 and regular, respiratory rate 40 and completely unlabored. Blood pressure, that's in the right arm, 80/55. Pulse oximetry, 85 to 90% on room air, just won't budge no matter how much oxygen you put on. He's comfortable and non-dysmorphic. You listen to his anterior fontanelle and there's no bruit, so you know that there's no AV malformation in the head. Chest is symmetric. On cardiac exam, you hear a normal S1. S2 is single. Now, I'm putting that in parentheses because we all know at 150 beats per minute, it's hard to hear a physiologic split. But for all intents and purposes, the S2 is single. There's a grade 2/6 systolic ejection murmur at the upper left sternal border. So think about what that might represent along with the single S2. And a little bit of blueness. Abdomen is soft. There's no organomegaly, so there's no sign of heart failure. Extremities, 2+/4+ pulses without delay. So the upper and lower extremities, as you palpate them both at the same time, are exactly the same. So think about what further testing you might want. Of course, the impulse is always to pick up the phone and call the cardiologist, and that's just fine, except when you can't find the cardiologist, which happens on occasion. So you get a chest x-ray. So with all of this, we're going to do a poll everywhere and tell me what is concerning about this chest x-ray and the entire picture. Okay, so we'll do the poll everywhere. Okay, it says host and panelists can't vote. Okay, we won't vote, but you guys vote. And do I just go for the next screen to see what the voting shows? Okay, I'm going to go back. All right, unfortunately, I can't. Let me see.
Let me ask real quick. I'll get back to you. Hold on.
All right, we'll try for the next poll everywhere. I don't know exactly what you guys are thinking, but all of these are concerning. Of course, there's a murmur. The saturations do not come up with supplemental oxygen. There we are. All of the above, 76%. Thank you. Chest x-ray shows a boot-shaped heart. So you had a choice of none of the above, which no one chose, and all of the above. So the nice thing is, all of the above is a correct answer, but if you chose A, B, or C, you're still correct. And we'll talk about why this is. So, are all murmurs nefarious? I know that when you take histories, and I do as well, parents will frequently say, yes, I had a murmur at birth as well. And so the hole closed. Well, we all know that murmurs can also be innocent and represent turbulent blood flow through something, either through a vessel, through a valve, through a hole. So they can be representative of everything, of anything. So the first most important part of identifying murmurs is to find their location. We heard that this murmur was a systolic ejection murmur at the upper left sternal border. So we're going to think about what cardiac structure lives at the upper left sternal border, and that's assuming that the heart is in the left chest. Then we talk about intensity. Loud, soft, just barely audible. Is it harsh? Is it machine-like? When you've listened to a lot of murmurs, some of those characteristics will come to mind easily. Systolic murmurs can be innocent, especially in newborns. Diastolic murmurs, however, that occur after S2 are always abnormal. They always represent something abnormal. So if you're hearing any sort of diastolic murmur, feel free to pick up the phone. Continuous murmurs, especially after birth, are often representative of a patent ductus arteriosus. Those can be accompanied by bounding pulses and widened pulse pressures when you look at your blood pressures. So just looking at the locations of the heart valves and the great vessels, and thinking about how you listen to the heart, at the upper right sternal border lives the aortic valve and ascending aorta. So aortic stenosis and those sorts of aortic coarctation sorts of murmurs can often be heard at the upper left sternal border. Coarctation murmurs can also be heard in the back because remember that the aorta is a big candy cane and goes all the way down the back of the spine. And typically you can hear a coarctation murmur better in the back, if anything. The right ventricular outflow tract lives at the upper left sternal border. That's along with the pulmonary valve. So we have our patient with a grade 2/6 systolic ejection murmur at the upper left sternal border. So think about what that might be representing. Mid-left sternal border, tricuspid valve. Also, the ventricular septum lives along the mid-left sternal border, so you'll hear VSDs. Mitral valves, best heard out toward the apex. Oh, and I might mention the other very common systolic ejection murmur of the newborn period is branch pulmonic stenosis, which once again, you'll hear at the upper left sternal border, and it radiates to the lung fields, typically in the axilla. So if you're hearing a murmur that kind of goes out through both lung fields and under the armpits, that's what you're hearing. Okay, and we won't go over this thoroughly today because we're limited in time, but these are representative of the types of murmurs that can be heard. The continuous murmur heard, of course, throughout the cycle, which is what makes it continuous. That to-fro murmur, as you can see, there's a lot of flow after S2. That will typically represent a semilunar valve that's incompetent. Most commonly the pulmonic valve, occasionally the aortic valve. We talked about the systolic ejection murmur. Whenever you hear a murmur that starts at S1 and goes all the way through and covers up S2 uniformly, that's a holosystolic murmur, most typical of VSD. And then I mentioned the diastolic murmurs that are uniformly abnormal. Okay, so what other data would you like? And here are your choices, and we'll try the poll everywhere again. Okay, I'm ready. Oh, this is awesome. It's going to work. Okay. And do I need to do anything to see the answers, or do they come up automatically?
I believe
I'll give you the results in a minute.
Okay, I'll be patient. I'm sorry.
No worries.
Great. Yes, I'll be honest with you. The only one that I wouldn't choose would none. He looks good and should be discharged. But actually, any of these answers would be appropriate. For extremity blood pressures, sure, you want to make sure there's no coarctation, and with a systolic ejection murmur at the upper left sternal border, that can represent certainly stenosis along the aorta, but also pulmonary valve stenosis or infundibular stenosis. EKG and chest X-ray, that's how we started in the bad old days. We didn't have echo right away. And so while we were waiting for the echo or echo machine, we would get an EKG and chest X-ray. And both of those can be helpful. And in this particular patient, we got the chest X-ray. It showed normal lung fields, which you would expect because there was no change with supplemental oxygen in his saturation. But it was a boot-shaped heart. And to some people in the audience, a boot-shaped heart may mean a specific cardiac defect. Getting an echocardiogram, great. If you have access at your hospital, that's always a good thing to do. If you don't, you can at least get these other pieces of data and get on the phone with the pediatric cardiologist and tell them what you're seeing and thinking. The hyperoxia challenge with blood gas, that's also a tool from the bad old days. We used to put babies in 100% oxy hoods, test their blood gas under oxygen and without oxygen and compare the PaO2. You can do the same thing with your pulse oximetry and see if there's any change as well. So we'll go over some of these things. So a few things. Do we hit the panic button? Is it time to send to a tertiary care center? Do you want more lab work, chemistry? Are you concerned the baby's septic? Do we need to start prostaglandins? And what does this child have? So before we move forward, I would put the physical examination together along with the chest X-ray. One of the most common cyanotic defects is tetralogy of Fallot. And that's what this child has with the single P2 and the grade 2/6 systolic ejection murmur. He otherwise looks great and is otherwise stable. We always worry about infundibular stenosis and tetralogy of Fallot spells. However, this child's saturations are 85%. There's a whole spectrum of tetralogy of Fallot, those that are severely cyanotic to those that are actually what we call pink tets that act more like ventricular septal defects. So I wouldn't necessarily start prostaglandins on this child because there are side effects, and we'll talk about that later. It's never wrong to get more blood work, and certainly a blood chemistry. If you have tetralogy of Fallot and the child has DeGeorge syndrome, you're going to see some calcium abnormalities. And you can always exclude sepsis with your lab work. So moving forward. So this brings us to the reason we designed CCHD screening, not just to torment you in the nursery, but because it actually has a role. So back in September of 2011, the Department of Health and Human Services commissioned a committee actually out of Children's National in DC. And they developed recommendations for newborn screening for critical congenital heart disease using pulse oximetry. And probably everyone in this audience knows that, quote, failed pulse oximetry occurs at 92% and below. We'll talk about this a little bit, but these guidelines were designed at sea level, and sometimes that's problematic for those of us that are at altitude, and we'll talk about why. The purpose of the screening is to identify congenital heart disease before the infants deteriorate on you, so that if you have concern, you can move those infants on out of the nursery into a tertiary care center where they can be further evaluated. And at the minimum, if you have echocardiography, get the echocardiogram as you're calling the pediatric cardiologist. 35 out of 50 states have adopted the policy. I was surprised to see that it was not 100%, but not all states have adopted this. I actually worked at a hospital previously that did not necessarily believe in CCHD screening, and they did not believe in getting blood pressures on infants ever. So everyone has their policy, and they're not all uniform. CCHD screening is obtained on all neonates, at least in Colorado and New Mexico, at greater than 24 hours of age. Think about why that might be, why we don't do it sooner. If they fail, it's done again at 48 hours. And once again, failure is represented by a pulse oximetry saturation less than 92%. How good is CCHD screening? Once again, we have this effect of high altitude and elevation. And in most of us that are living at altitude, our pulmonary vasculature has adapted to the higher altitude living. PaO2 is a little bit different, and the effect on lungs and constriction of the blood vessels can be problematic in an infant that is transitioning to neonatal circulation. I've shown you here the patent foramen ovale, that nice trap door that helps the fetal heart form normally. In fetal life, shunting goes from right to left. If the pressures are equal in both atria, that shunting can be bidirectional. If the pressure is higher in the right atrium than in the left, that represents right to left shunting, and that will make your baby blue. And typically that's due to, in the newborn period, the fact that the pulmonary vasculature has not relaxed yet. And it takes a little while at altitude. What can we miss by relying just entirely on pulse oximetry? I want you to think about that, and we will discuss that further down the line. There are other conditions than high altitude that can give false positive screening, and those would be extracardiac situations. So pulmonary abnormalities, pneumonia, sepsis, those sorts of things can give you abnormal CCHD screening as well. How does pulse oximetry work? This is just the brief Reader's Digest version. My daughter thought these looked like tomatoes. I guess they do look a little bit like tomatoes. So we'll call them tomatoes, but they're really red blood cells carrying oxygen. And what pulse oximetry does is it sends light through whatever structure, the finger, the toe, the ear, and it measures changes in light absorption in the oxygenated or deoxygenated blood. So you can see with high absorption, the blood is more oxygenated. With low absorption, there's lower concentration. Things that can affect your pulse oximetry include the location of where you place the pulse oximeter. I'm sure everyone here has tried to place it in several different areas when it doesn't seem to be picking up or correlating. If tissue perfusion isn't good, pardon me, if the extremities are cool, sometimes it won't pick up normally and it'll give an abnormally low pulse oximetry reading. Darker skin color makes it more difficult for the pulse oximeter to be sensitive. Anemia, if there aren't enough red blood cells. And I didn't include this, but in those that we already know are cyanotic, the more cyanotic they become, the less reliable pulse oximetry is. Okay. So just to go briefly over fetal circulation so I don't bore you to death and completely lose you. On the left there is fetal circulation. And as you will recall, mom is doing all the work through the placenta. Oxygenated blood comes through the umbilical vein, travels up into the IVC, through the ductus venosus into the IVC, to the right atrium. And typically, because of pressure differentials, goes across the foramen ovale into the left atrium, out the left ventricle, and then that oxygenated blood preferentially goes to the brain for obvious reasons, and then mixes with the deoxygenated blood to perfuse the rest of the body. The deoxygenated blood then returns from the head and the feet and from the pulmonary veins, and we'll talk about this. That blue blood comes in and once again circulates into the right ventricle and goes back out toward the pulmonary arteries. Only 10% of this blood flow goes to the lungs. So as you know, mom is doing the work. The lungs are kind of passive. Babies learn to breathe over time. And then after birth, as you know, when the placenta is cut out, that's when these lung masses are asked to work. But in fetal life, the majority of this blue blood is then shunted back down into the lower extremities. Partial pressure of oxygen of the fetus, PaO2, is about 37, pretty low. So that's where they're used to living. Baby comes out, cord is clamped, and baby takes a deep breath, lungs expand, and the pulmonary vasculature for the first time is asked to take the full cardiac output. So during transitioning, and some kids are slower than others, deoxygenated blood from the head and feet through the right atrium into the right ventricle, once again out to the lung arteries. And whether or not this blue blood is then shunted across the ductus is going to be dependent upon pressure differential. So if the pressure is higher in the lungs than the descending aorta, blood will go from right to left down this descending aorta. If the aortic pressure is higher, which is what we're hoping for, then if the ductus is open, the shunting will go from left to right and back out to the lungs. So initially, these pressures are equal. Occasionally, the RV pressure is higher, especially at altitude. And so with higher pressure on the right side, one would expect that right to left shunting. As the baby transitions and the vasculature begins to open up along with the alveoli here, the pressure begins to drop on the right side, increase on the left side, and you begin to develop this normal adult circulation. Typically, the ductus arteriosus will close within the first 24 to 48 hours of life. Some kids are a little bit later. The addition of oxygen or higher saturations aids in closing this ductus arteriosus. And then there are other methods of closing in the premature infants, and that's another discussion. Okay, so just once again, another cleaner picture of fetal circulation. What I want you to take away from this is that everything here in fetal circulation, so in persistent fetal circulation, these saturations are going to be uniform. This is a total mixing picture. And so typically you'll end up with saturations of 75% and lower if there is persistent fetal circulation. Newborn heart, once again, the circulation becomes separated, hopefully, with the blue blood going out to the lungs, red blood coming back to the left atrium, left ventricle, and out the aorta. This is what we're hoping for, this picture. All right, so ductal dependent lesions. What does it mean to be ductal dependent? Well, these are just a couple of the lesions. We're going to look at the left-sided or systemic versus the right-sided or pulmonic lesions. So here's coarctation of the aorta, which we're hitting pretty hard because it is the most commonly missed cardiac defect. So with coarctation of the aorta, coarctation can be anywhere, but typically in the ductal region, what we call the juxtaductal region, and there can be some ductal tissue within this area of the aorta. So when the ductus finally constricts, there may be further constriction, as you see here, of that coarctation. So what happens is if there's antegrade flow, it has difficulty getting through that constriction, just like when you squeeze a garden hose. The water can't get through. This is the creation of that murmur we were discussing. And if not enough red blood can get through to the descending aorta, the pulmonary artery obligatorily sends that desaturated blood down the descending aorta to perfuse the body. So this ductus is what keeps these patients from getting into trouble. And once again, in the bad old days, when kids were sent home with coarctation unwittingly, when this ductus closes was when they would get in trouble. They would present to the ED, typically looking septic, pale, shocky, just not well. And that was when the diagnosis was made. Right-sided heart lesion. So this represents pulmonary atresia. There's no pulmonary valve here. So blue blood comes in from the head and the feet into the right atrium, goes into the right ventricle, but cannot get out anywhere. Its only egress would be from the right atrium to the left, allowing that blue blood to escape and mix with oxygenated blood through the left ventricle, then going out through the aorta. And the only way blood can get to the lungs is through the ductus and back out into the pulmonary arteries. So this is another form of ductal dependent lesion. So next case, this is a 2-kilogram female born, spontaneous vaginal delivery, good APGARs. She's a beautiful baby, but she does have a web neck and wide-spaced nipples. So she's just a little bit off. She's comfortable. She learned to breastfeed immediately. Her height, 47 centimeters, so a little on the lower side. Weight, 2 kilograms. Her heart rate is 180 beats per minute and regular. Respiratory rate, 40s. Pulse oximetry, 95%. And this is in the upper extremity. Notice this heart rate of 180. So one of the things you would want to do is make sure this is sinus rhythm. And so I'll just give this to you. This was sinus tachycardia in this baby, but this is how peaceful she looked. Once again, anterior fontanelle open and flat without bruit. When you listen to her chest, there's a normal S1. You're actually able to hear a physiologically split S2 at a heart rate of 180, which is pretty amazing. But I'll give that to you. She has a grade 2/6 systolic ejection murmur location, mid-left sternal border, not upper left sternal border, mid-left sternal border. And you're lucky enough to get a good exam of her back, and you can hear it back there. Her abdomen is soft without organomegaly or mass. She has mild edema of both of her legs. And the pulses, there's a differential. So you're getting better pulses in the upper extremities, and you're having a hard time feeling the pulses actually in the feet. So you go to the groin, where you're only getting a 1+/4+ pulse. And there's a mild delay where it reaches your fingers. So what data would you like? Another poll everywhere, please. Did we put this one on poll everywhere, or did I miss this one? Oh, there we go. Okay, sorry. I don't mean to be impatient. I just am always worried I've done something wrong.
You're good. You've got everything covered.
Excellent. Okay, this is another one of these questions where none of the answers is really wrong. Just some are more right than others. It would not be wrong to get an EKG and a chest x-ray. And actually with coarctation of the aorta, there's something called the number 3 sign. So you can actually almost and sometimes see that indentation of the aorta, and it looks like the number 3 as you're looking at the chest x-ray. EKG may be a little bit nonspecific, but might show you some left-sided force abnormalities. Letter C, lab data. Once again, never wrong to get lab data and make sure the child isn't septic or have other issues that would cause poor perfusion. What I was going for were both letters B and D, right upper arm and leg pressure. So if you want to remember, just go on the right side, right upper, right lower, but either leg would work. And then upper and lower extremity pulse oximetry, and think about why that would be. So what we got for this child, and I'm going to show you different forms of interrupted arch and coarctation. What we got for this child was 95% on the right upper, 92% in the left upper, and then the legs were both 85%. Blood pressure is a little bit high in the upper extremities, and look how low they are in the lower extremities. And we cardiologists typically look at systolic pressures. I know in the nursery, we typically go for mean arterial pressures, but we're looking at the systolic pressure, between that. So there's a 60 millimeter mercury gradient between the right upper extremity and the right lower extremity. The other thing I want to point out here, look at the pulse pressure, 100/40. That indicates to me that the ductus is still open, hopefully, and the baby is young, so hopefully that ductus is still open. And if you ever get this, and I have been subject to this myself, where you put the Dynamap on and you hear do 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 do, and you keep hitting the button until you realize it's not the Dynamap and it's not your cuff, it's that the blood pressure is not picking up. So if you ever hear that more than twice, start thinking that it may not be the Dynamap. I'm showing in this upper panel different types of aortic arch interruptions. This would be the extreme of coarctation, right? The most common type of interruption is type B, but just for all intents and purposes, you can see that there's perfusion of the head and neck vessels, but then the aorta stops. It literally stops and is not formed from here. And so the only way to get blood back down the descending aorta, in this case, the left subclavian artery, is by the ductus arteriosus. So once again, ductal dependent lesions. All right. All right. So differential diagnosis. What I was describing here in this tiny baby, she wasn't tiny, but small for gestational age baby with a web neck, wide space nipples, and edema is Turner syndrome. And with Turner syndrome, we always think of left-sided heart defects. I don't expect you to know that, but I wanted to give you a big hint about that coarctation, which is the most important part of this. What more information would you like? You got the blood pressures. I think getting an echocardiogram stat, this would be one time you would want to call stat, would be a good idea. Does the baby need to be in a tertiary care center? With that kind of blood pressure differential, yes, you need to get her out of your nursery. Even though she looks good, you need to get her out as soon as possible. And while you're getting her out, get that IV access and start prostaglandins. So just a brief discussion of left-sided heart defects, some of the things we can see with Turner syndrome, but in general, bicuspid aortic valve. Bicuspid aortic valves occur in approximately 10% of the population. So there's a pretty high predisposition for bicuspid aortic valves. Coarctation, a lot of times coarctation goes along with bicuspid aortic valve. Schoen syndrome is a series of left-sided heart defects. So there's mitral stenosis, aortic stenosis, coarctation. Those are nasty to deal with. Pardon me. And then the extreme would be this hypoplastic left heart syndrome. Fortunately, with hypoplastic left heart syndrome, those kids tend to be blue right away, just because, pardon me, the right side of the heart is doing all the work. The left ventricle is just kind of along for the ride. So what clues did you have? You had a child with a murmur. In this case, she was a little bit dysmorphic. So anytime someone's dysmorphic, I always look for heart disease, but I'm a little biased and cardiocentric. She also had the murmur, she was dysmorphic, she had blood pressure differentials, and she had what we called a pulse oximetry split, where the upper extremities were more saturated than the lower extremities because that ductus was going from right to left, and the pulmonary arteries were supplying the descending aorta. So last case is the case of a 5-kilogram male, so big guy, APGARs of 7 and 8. And this kid was working to breathe from the get-go. I'll give you this piece of information. Mom had gestational diabetes. So vital signs: height, 51 centimeters, weight, 5 kilograms, heart rate 150s, and regular respiratory rate, hang on just a second, please, 60. Pulse oximetry, 75 to 80% in both the upper and lower extremities. So no split at this time. HENT normal exam. And for all intents and purposes, your cardiovascular exam is normal S1, but it's a narrow split to S2 with an increased P2 component, and you don't hear a murmur. No organomegaly, pulses are equal. So think about what this might be. This kid wouldn't even make it to CCHD screening because they're declaring themselves right out of the womb. What data would you like? We'll go to poll everywhere. While we're doing this, when do you recommend getting 4-point blood pressures on new babies? Currently, we do it only at admission, but it has always seemed too soon to me. So, Lindsay, you're exactly right. I'm a little biased, and I would probably advocate getting blood pressures along with the CCHD screening. So at 24 to 48 hours, or even just before you're ready to send the baby home, because hopefully by then the ductus is closed. Oh, you're welcome. Thanks for your question. Yes, everybody, I think you can go with all of the above. Don't you wish that I did all your multiple choice exams? Because I try to make it obvious to you. But you're not wrong to do any of these things. And certainly chest x-ray and EKG. So let's start with that. Actually, on the chest x-ray, if this is complex congenital heart disease, you're likely to see normal lung fields, likely. There are a few defects like total anomalous pulmonary venous return. Pardon me just a minute. Where the lung fields will appear congested because if the veins are obstructed, blood can't return normally to the heart. So it can be helpful. But if you're dealing with pulmonary hypertension where there's no blood or little blood getting out to the lung fields, you're going to see dark fields. The EKG can be helpful from the standpoint that if it's pulmonary hypertension, you're going to see a great deal of right-sided force. It's not going to be diagnostic, but it might help you. The hyperoxia test we're going to talk about, that is a very useful thing, and we'll talk about why. Lab data, yes, please make sure this baby isn't suffering from something else. Sepsis, make sure that they're not anemic. There are several other things you're going to look for in addition to cardiac disease. So although I'm a cardiologist, I do believe in looking at other organ systems. And then once again, the echocardiogram is going to be the thing that's going to be most diagnostic for you. So all of the above, I would be doing all of the above. And with those saturations, I would be on the phone with the cardiologist as soon as I found out that oxygen saturations were not helping. And if the baby stayed distressed like that over 24 hours, actually, if he's really distressed, I wouldn't even wait that long. What is a hyperoxia test? So in the bad old days, we would intubate these babies actually and turn the FiO2 up to 100%. So we were able to get really pure PaO2 blood gases. And our rule was if your PaO2 was greater than 150 millimeters of mercury on 100% oxygen, and typically upwards to 300 is what it should be with a structurally normal heart, then you were dealing with pulmonary hypertension. If less than 150 millimeters of mercury, say, for example, this is transposition, you can see a partial pressure of oxygen as low as 35 to 60%, which can be a little bit frightening. If you can measure blood gases, great. If not, just use your pulse oximeter. And I realize you're not going to intubate all of these babies. It's what we used to do, but we now can use oxy hoods or blow by oxygen, knowing that we're not really giving an FiO2 of 100%, but we're at least raising the oxygen level. So hyperoxia test, great thing to do while you're waiting for some other testing, and easy. Prostaglandins and side effects. So prostaglandins, prostans, PGE1s are naturally occurring hormones. There are several different types of prostaglandins with different properties, but I'm talking about PGE1 that we administer to maintain the ductus arteriosus patency. Once again, when the placenta is removed, this PGE1 supply is gone. As mentioned, the mechanisms of actions of prostaglandins can be either vasodilatory or vasoconstrictive. PGE1 tends to be more vasodilatory. It acts on both the pulmonic system and systemic system. So if you're dealing with pulmonary hypertension, for example, it may help to open up the lung fields, but realize you may have a trade-off with some systemic hypotension. Dependent upon the dose of prostaglandins, babies can become apneic. That's one of the major side effects. So be prepared to intubate if you start prostaglandins. Over time, there's an antiplatelet effect. So prostaglandins can keep the platelets from aggregating normally. It also can slow some of the white cells. But once again, in the immediate period, you're not going to have to deal with those side effects. All right. Can PGE make the picture worse? Well, as I stated, in the case of obstructed pulmonary veins, you can imagine if blood can't get back to the heart, and you're pulmonary vasodilating, you're sending a lot of blood out to the lungs, but it can't get back to the heart. So with TAPVR, it is the one cardiac defect where if you start prostaglandins, the patient may actually look worse. That doesn't mean you don't start prostaglandins because you may not know what you're dealing with. But if you have a good sonographer and the cardiologist has called you back and has said, this is TAPVR, then prostaglandins is not the answer. The other case where prostaglandins, it won't make things worse necessarily, but isn't helpful, is if you don't have a ductus. So there are a couple of defects like truncus arteriosus up here, where the aorta and the pulmonary artery are still one trunk and there's no ductus arteriosus. You can put prostaglandins on all day and it's just going to give you side effects. It's not going to be helpful. Is it the wrong thing to do? No. Until you get a good diagnosis, it's never wrong to put prostaglandins on. But with this sort of defect, it's not going to be helpful. Other defects where it's not going to be helpful are the non-ductal dependent defects, such as VSD, ASD, AV canals, those sorts of things. And those may be less critical for you. So I just gave you the answer. Let's do a poll everywhere on this. All right. Okay, very good. So truncus arteriosus doesn't have a ductus, so prostaglandins won't do anything. Total anomalous pulmonary venous return is not a ductal dependent lesion, although those kids can be quite blue and in trouble. And prostaglandins may pulmonary vasodilate, the blood will stay out in the lungs, and it won't be able to return to the heart normally, so they could get worse. Atrioventricular septal defects, or AV canals, those are the babies, quite typically Down syndrome babies, where they have a large atrial septal defect, a large ventricular septal defect, so the blood comes in, it's a total mixing lesion. They will look blue, but adding prostaglandins is not going to do anything necessarily except to pulmonary vasodilate. So that sort of defect, prostaglandins will not be helpful. So if you got A, B, or C, that's correct. All of the above is even better because you got all of them. Pulmonary atresia is that one case where the pulmonary valve is non-existent. So that blue blood cannot get out. It can't get out through here. It has to go through the patent foramen ovale and back out. And this is a ductal dependent lesion. Okay. So is the baby just slow to transition, or is it pulmonary hypertension? If the baby's not in too much distress, if you can wait 24 hours and see how they do with transitioning, especially these large babies that are infants of diabetic mothers, then do so. If you're in trouble and you're concerned that you can't maintain systemic pressures, the baby's acidotic, you cannot make the baby comfortable, then feel free to get them out of your unit into a tertiary care setting where they can crash onto ECMO if necessary. All right. Summary of the neonatal cardiac exam. 1% of all congenital heart disease. It's not always picked up on prenatal ultrasound. We've gotten a lot better, but we still miss some. Transposition, for example, has 4 normal-looking chambers. It's just that the great vessels don't come off where they should. So we still miss things. Your role may save a life or prevent chronic deficit. Pulse oximetry alone is not enough. And I agree that for extremity blood pressures, if you really want to be thorough, get them after birth, but also get them before the baby goes home. False positives, if there is shunting at high altitude through that patent foramen ovale from right to left, babies can have structurally normal hearts, but be blue and fail their screening. And those are the babies that you send to us and we call you up and say, heart looks fine, but the pressures have been elevated. You can try, in those babies, you can try adding oxygen to see if it helps. False negatives, infants with dark colored skin, coarctation, you may not see that split right away. AVSD, as I mentioned, so those atrioventricular septal defects or canals, the occasional tetralogy of Fallot, that's pink, where you're not seeing a lot of stenosis in that pulmonary area, and occasionally Epstein's anomaly. In summary, the physical exam is crucial. Get your upper and lower extremity blood pressures and pulse ox. Listen for murmurs. Not all identified cardiac defects require urgent transport to a tertiary care center, but feel free to ask the cardiologist. Not all critical heart defects are ductal dependent, as we discussed. If in doubt, obtain access and start prostaglandins. Just be ready for the side effects. And don't be afraid to contact your friendly neighborhood pediatric cardiologist. And feel free to ask questions, and I will look in the chat area. Thank you for listening today.
Hi, Dr. Grenier. This is Brenda. Oops. This is Brenda Gonzalez. We miss you down here.
Thank you so much. I miss being there, and I actually have asked if I can come down part-time. So I'm hoping both institutions can talk, and I would love to come down once a month if I can.
Well, thank you for making I wasn't sure how interesting this would be, but you made it very interesting. I learned a lot.
Oh, good. I'm so glad.
There's only one question that we haven't addressed as we went along. For those of you, Myrna asked early on, how do we find out which states haven't accepted the CCHD screening protocols? And Kathy put a nice article from the CDC in the chat, so you can browse that.
Great.
You already answered Lindsay's question. That was a really good question, Lindsay, because I've always thought that myself. We do tend to get it the minute we get the babies to the unit. The blood pressure is the 4-point, and I've always thought that was just a little too soon. There's one final question. We talked about internal bias yesterday and its effect on WOC and newborns. To your knowledge, is there a difference in the CCHD morbidity mortality distribution based on ethnicity and color that is not attributed to prevalence in general population? And then she put in, she clarified saying, is there a difference in distribution based on ethnicity and color, or are these equally distributed among all ethnicities?
So are you talking about congenital heart defects as far as distribution across all ethnicities?
I think she is.
Okay. If that's your question, there seem to be pockets, and I would love to look at this. So if anyone's interested in the research, let me know, because I've always wanted to do this. There are pockets of congenital heart disease. And so I've noticed actually in Navajos in particular, out toward Fort Defiance, there tend to be more aortic abnormalities than in the general population. Here in Colorado, there are pockets of truncus arteriosus, which you don't see in other parts of the United States. And just thinking anecdotally, that crosses all ethnic groups, but it tends to be geospecific. So is there something in the environment that's unmasking a genetic defect? There are papers looking at ethnicities and congenital heart defects, and no one has really identified specific abnormalities. And so the answer to your question is, with the current literature, CHD uniformly hits all populations. Now, that being said, our neighbors in the rural areas, and those are the areas we really, really need to reach, those are the ones that don't get prenatal care, that cardiac defects are identified later. And those are the kids that are in distress when they come to you and have the highest morbidity and mortality because they've been hypoxic for a while. So yes, interesting. Sounds like a good research project. Yes, please feel free to give out my email address. I'm glad to talk to anybody about any of these things. And if there's interest in the epidemiology, I've got data from Southwest Texas, where we saw a lot of heterotaxy, New Mexico, and now Colorado. So always glad to talk about this.
There's one more question from Connie. She asks, if you've got an infant of an uncontrolled diabetic mom with no fetal ultrasounds, what are the chances you're going to miss a cardiac defect, as in percentage of babies with above mom's probably of having a heart defect that may not be caught on CCHD? Should we consider an echo in these babies on a normal appearing baby?
That is a fantastic question. And certainly that is an indication for prenatal echo. So anytime we have someone with gestational diabetes, but particularly uncontrolled gestational diabetes, yes, the incidence goes way up, and it depends who you read, but it can be as high as 5 to 10%. Just with morbid obesity, you add diabetes, that's yet another factor. And we're also finding, of course, preeclampsia is affecting what we see as well. So is it wrong to get an echocardiogram on these babies? Not necessarily. It's not considered. So if you look at the appropriate use paper, category A, B, C, and D, it's going to fall in category B and C where it's not always indicated. I would tell you this, if this baby is going back to Fort Defiance and you may never see them again, I'd err on the side of getting an echocardiogram, no matter how much the cardiologist and the echosonographer are complaining about reading too many studies that day. That's when you put your fingers in your ears and you're like, okay, I know you guys are having a hard time, but I need this echo because I'm going to send this baby back and I may never see them again. Yeah, and the CCHD screen is good. It's not foolproof, but it's good. So that's a very, very good question. Thank you.
Does anyone have any more questions for Dr. Grenier? It doesn't look like it. Thank you so much for joining us for our conference, Dr. Grenier. It was so good to see your sweet face.
Oh, thank you. It's my honor, and thank you for putting up with the background. And I sure hope I get to see all of you guys again. And please feel free to write to me and ask questions.
Okay, we'll be sure and share your email address, and hopefully we'll see you soon.
I hope so. Have a wonderful day.
Thank you. You too.
Bye.
Bye-bye. It looks like we have time for a short break. We'll be back at 9:10 with Dr. Jason McKee.